Alison.
I'm Penny Newman. I'm a GP and consultant in public health. I also work at Colchester Hospital. I know many of you here, and thank you all for coming. It's just amazing to see you all here. Andrew, do you want to say?
Yeah, I'm Andrew McDowell. I'm very pleased to have met a number of you in the room before. I work with the Performance Coach, and we've been very happy to partner with East of England in this wonderful project.
So what we're going to talk to you, and thank you so much for our incredible speakers. I think you summed up the position so well and articulate well before, even with the time pressure, so thank you so much. We're going to really talk from the East of England perspective, and I'm going to talk really from my own perspective as a clinician in terms of what we did and why. I'm going to speed through the first slides because I think they've already been captured so well before. And Andrew's going to talk about the programme and what was involved. So, you know, I'm really proud to be part of the NHS and part of an NHS family. My husband also works for the NHS, not my children. And that is because actually we're all here to improve the health and well-being of the patients that we look after. And I really like this concept of well-being. I think it's really important now to thrive in the presence of disease because we can no longer treat and cure most diseases that we see in our patients with long-term conditions, the ability to thrive in the presence of disease. And the NHS Constitution recognises this, the importance of the NHS is improving the health and wellness of patients, and also that helping patients take responsibility for this. National Voices, Angela mentioned, has a fantastic statement. Patients want to take control. And we now have a new Chief Executive of NHS England who recognises that we have to help them because otherwise the NHS is not sustainable. And we know, you know, from what Steve was saying about patient activation, there's huge potential to save money in this very challenging time. So, you know, we all know that this is something that has to happen. And it's becoming more urgent because of all the problems with long-term conditions. And I recognise, I just want to add one more thing to what Steve has to say. You know, I worked in inner city Ipswich, and my patients who are 80 with long-term conditions, incredibly frail, housebound, you know, really frail at 80. I compare that to my mum, middle class, living in Henley, and her friends who have very sharp elbows. In fact, my mother's just come back from Barcelona. So the difference, I think, in what's happening between our different communities is just really shocking. And we probably all recognise that in our friends and families. So I think, you know, it's really important to focus on those who are poorer and the elderly. You know, in the poorest, I think they have 60% more prevalence of long-term conditions and 30% more severity. And we mustn't overlook, I think, those health inequalities. As a clinician, you know, we're just carrying on doing the same, but it's not working. I think, you know, Angela pointed out very clearly why the current approach is not sustainable. 50% of patients walk out from seeing their GP, and this is evidence from the States, not understanding what they've been told. I think we've got between a third and a half compliance with medications we prescribe, and only about 10% actually make the lifestyle changes that we recommend. And we're not trained in behavioural change, in science of behaviour change. Maybe at medical school we might have had a little bit of training. Nurses and podiatrists and physios, maybe hopefully a little bit more. But then after that, I think I've been in Suffolk for 9 years. There's one afternoon session on consultation skills, but thousands of courses on COPD and heart failure. So actually, we're not really changed in the science of behaviour change, and certainly no updates. And as Steve said, the alignment between what patients want and what we provide is poor. But I mean, even basic communication skills, and it's, I think, what Dr. Granger is doing around Hello, My Name is a fantastic campaign. But I mean, shouldn't we take that as given that we introduce ourselves? I mean, really, that's just a really basic thing. And doctors interrupt within 12 seconds. There might be, you know, someone ringing up or the door opening or just basically cutting someone off. And we know that that's associated with a poor patient experience. So even basic communication we can improve. And I quote Angela here, paternalism breeds dependency, encourages patients to be passive. And that's the authoritarian, expert-driven, advice-giving role that actually, you know, we're sometimes are most comfortable with. And the impact is overwhelming. You know, I mean, I've got a few GPs here, I'm sure, who know what it's like on duty day with 60 to 80 patients coming through the door and telephone calls and everything. We just, you know, we're working 12, 13-hour days in general practice. It's just not sustainable. We know that 10 minutes is not enough. But we didn't know all that research when we first started out in 2010, and we had a different model on long-term conditions then. This is the Kaiser pyramid that many of you may be familiar with, which shows that actually we need two sorts of strategies in order to deal with long-term conditions. One is supporting and managing patients who have coming in all the time into hospital for the same thing and helping them being looked after at home. But the other is the vast majority of people who need to look after themselves and be supported in doing so. And this was the model of the past, and Sue's going to tell us about the new model at a workshop later. But this is what we were working with when we first developed this approach in 2010, when I was at Suffolk and working in NHS Suffolk as lead for long-term conditions. So we were sort of trying to address the different parts of this Kaiser pyramid, and people were saying, fill this form in with patients, you need to do health care plans. And I was thinking, well, they're going to take a long time, and I'm not really sure what I'm supposed to be doing, and I can't really fit that in my 10-minute slot. So what else could we do that would be really useful? And at the time in 2010, I was sort of at loss on how we could fill this objective. And I went on an executive coaching training course that actually Karen organised, which was life-changing, really. And I met Andrew. And I said, these skills are fantastic. I mean, I never realised I could have this sort of conversation. I've been doing it completely wrong. And I just love these skills. I can use them with my family, with my friends, with my colleagues, with my patients. And Andrew said, I was training medical students in those skills 12 years ago in Australia. So we had a conversation about this, and we were very, very lucky that at that time, I think it's come back, the Regional Innovation Fund was around, and we applied, and we were successful, and we got £100,000 to train practice nurses in 7 practices in Suffolk. And we designed the health coaching training that is now used, the sort of first stab at that, and trained up practice nurses over a four-day course, and that was evaluated, and we've got a workshop on general practice after lunch, so I'll be saying a bit more about what we found in that evaluation then with 2 of my GP colleagues. But I had a bit of underspend, so then we rolled it out to CCGs, and we then trained multidisciplinary teams in 4 CCGs with the previous national long-term condition programme team, and then in 2013-14 we were fantastically lucky and fortunate to get the money to procure the contract now with TPC. So it's been 4 years in the running, and to see you all here today is just incredible from that conversation in 2010. So when we went out to procurement, what we wanted to do was we wanted to equip clinicians with new skills, knowledge and behaviours, because I sort of felt that I didn't really, as a clinician, I didn't really know enough how to do this, and I was sure that my colleagues wouldn't know either, and that we needed new techniques to help promote self-care, motivation and responsibility, but also, basic communication skills around improving patient satisfaction. That wasn't something completely different. It's not another new consultation skills, but builds on what we know, so that we can have a tailored conversation to patients. With some patients that come in, they're very, very ill, and obviously health coaching isn't going to be appropriate. But with others, we need to tailor our approach. And so Andrew's going to talk about exactly what we did, but we're absolutely delighted that when we first started rolling out the program, which is when everyone was setting up new organisations and everything had changed, that the uptake has gone from strength to strength. And I think actually to have trained up 800 clinicians in this year, when everything's been so new, is testament to how important clinicians think it is and how useful it is for them, reconnecting them with their values and what we're here for. Obviously, it's been a wide range of clinicians that we've trained up: nurses, allied health professionals, and doctors. I'm now going to hand over to Andrew about what we actually did.
Thank you. So, for those of you who may have actually experienced some of the training, been involved in it, effectively what we designed was a 2-day intervention. which was split a week apart, so people had a chance to go away and practice some of their skills. We also, as part of the project, have developed a number of people who could then learn how to deliver the program internally for your organisations to create a resource going forward, which for me is very, very important, because the only way that you actually get a culture change within an organisation is for an organisation to take it on board. So we now have, I think, 16 or 18 people who we've accredited to actually roll the program out further. So those numbers that Penny was talking about before of 800 could easily be 3,000 or 4,000 this time next year, if those people are freed up to actually take it forward. Some of you will know of coaching, or will have heard of coaching before, and effectively what coaching tries to do in any situation is create an increase or a change in performance. If we think about this in the health context, really what we're looking for is a change in someone's ability to self-manage differently. So we're really looking at how we can use a different kind of conversation to enable people to be more aware of what's happening for themselves and therefore able to take more responsibility. Okay? That's really what we're trying to do with the health coaching conversation. Change the conversation in the ways which we all know are important in order to do that. And particularly around long-term conditions where, as the point's been made so clearly already, such a small amount of intervention that we have in relation to the way someone actually manages their own life, we're trying to support someone to change their relationship to that problem or illness so that they can be freed up to self-manage more creatively. And what that invites is a different kind of conversation, a different kind of role for a patient and a clinician to play. Ruth Woollever is one of the people who are writing quite proficiently about health coaching in the US at the moment, and she's saying that effectively we need to see patients being able to determine their own goals, to be involved in some sort of self-discovery in order to actually start taking that responsibility. We need to also, of course, think about there are times where we need to provide content education, but effectively it's about encouraging people to actually self-monitor and manage going forward. It means the clinician has to change a little bit as well, and we talk a lot about activated patients. A very important part of the intervention that we've developed is that we're asking for activated clinicians. We want clinicians to think differently about their role and to experience a mindset shift in how they're thinking about what's their role in this situation with this patient and how can it encourage behaviour change if it's possible. And what we've done really is drawn on a number of different areas to actually make this work. So we've taken some of the key concepts of behavioural medicine and health psychology, which there's masses of research out there about. We know they work, we know it's useful, we know it makes a difference. So we can pull together the ideas of behaviour change, social cognition, patient activation, stages of change, all of these good things that we know about, motivation interviewing techniques, positive psychology. We can tie it up with the structures we know from leadership and executive coaching, which we know get performance shifts with people. So what we've done effectively with the program is taken the health psychology ideas, put them into a coaching framework for having a different kind of conversation with people, which also enables people as clinicians to use their knowledge, use their experience, use the fantastic clinical skills they already have, and clinicians pick it up really quickly. Have you ever tried to tell a clinician what to do? Doesn't work too well. So what we've found is that what we have to be is very careful in how we actually engage people in this process of discovery as clinicians, because we're trying to encourage them to think about their role differently, using their clinical skills, creating more of a coaching-orientated relationship with people to support behaviour change while encouraging self-determined goals and activation. What's in the program, effectively, just so people know if you haven't experienced it, is we try to help people understand what coaching is through the foundations of what coaching's all about and how it works before we try to apply it clinically. Okay? That's really important because we want people to coach themselves into the idea that this could be useful. Everybody knows about the importance of patient self-determined goals, but it's quite hard to get there as part of your role, if that makes sense. We're surprised to find that the learning around being directive and non-directive and the impact of that is really important for clinicians. They learn quite a lot from that. Structuring health conversations, basic skills of listening, trust and rapport, how to use challenge in a supportive way to help people change their relationship to their problem, some positive psychology, readiness to change, and structured into health coaching behaviour change techniques. Okay? That in itself would be fine, but it's how you do it that makes a difference. And for clinicians who are clever people, like working out things for themselves, we need to make it highly experiential. So they're actually practicing immediately. They're learning skills immediately, giving them time to actually experience what it's like to coach and be coached and to realise how difficult that is to keep their mouth shut, to actually not tell someone what to do. And that's fine, it works for some things, but if it's about a behaviour change, it just won't have the impact, because we know only 10% of people follow the lifestyle advice we give them. Okay? So it's really about how we do it, which seems to have been quite useful. The results that we've seen emerging is that people walk away with a mindset shift. The idea of being able to have a coaching mindset which is relevant to just about every patient that they see. So just the basic ideas of things like, actually, this person is probably more resourceful than I think they are. Just holding that as an idea is a great place to start, and it's relevant to everybody we see. Okay? There are skills that we use, all the skills around supportive challenge and listening and empathy. These are useful also in most clinical interactions. Maybe not where you're even looking for a behaviour change, but effectively there's a generalisation of those skills into most interactions people have. And then finally, there's this series of techniques that people can learn and use. This is interesting. Ooh, magic. Dum, dum, dum. Are we okay? I will get there eventually, but the idea of getting down to some skills that people can actually take away and use to have behaviour change conversations with others. Good luck following the rest of this presentation. Personally, I'm finding it quite interesting. Penny.
The point on the previous slide was that, what I think is really, I'm a GP and I'm also trained in public health. And I love public health and I love general practice, but they don't I find it really difficult integrating the two. And what I think happens in general practice, if someone's got a behavioural issue, around smoking, diet, exercise, we don't focus on that quite as much. And we send them to the practice nurse, or we give them, exercise on referral. But we tend to focus on the, disease. And I with my public health hat on, I'm thinking, patients don't come to us in silos. We put them in silos because it fits our agenda and it fits our priorities and it helps us make our case. But patients don't come to us in silos. So what I love about health coaching, which I think Angela so beautifully articulated, is that this is a tool about setting patient-centered goals. The elderly gentleman who the physios were going to see, and there's some fantastic stories in the back of your amazing booklets that Karen has developed, but the stories that our trainers have given us. So one gentleman, the physios were going in and he wouldn't get out of his chair, he'd had a fall and he'd lost confidence. And what got him up was getting up to the computer upstairs to be able to Skype his grandson. And would that be frail elderly or integrated care? The point was, the goal for him was to get upstairs, and in achieving his goal, he met the physio's goal of walking 2 yards, 5 yards, whatever. Another goal, an elderly lady wanted to get up and to get moving after a fall in order to get to the sea in Southend, to get to the Esplanade. Another case was about a gentleman, end of life, and he was in bed and depressed, and they worked with him, and he decided he wanted to teach his son how to look after his vegetable garden. That got him out of bed. It helped our goals that we didn't have to go and see him so often, but it helped him and get out of bed and have a better end of life. The patient that came to see me had been on 4 or 5 different sorts of HRT, who recognised that she wanted to sort her problems out with her family and her relationships, and actually the 4th sort of HRT wasn't going to work. These patients don't come to us in silos. They come to us, and I think it's so important with health coaching to help patients identify what goals they want to achieve, which work across the different silos. So that's why I think health coaching really is important, integrating lifestyle, decision-making, and long-term condition management for that patient in order for them to achieve their goals. And that was the slide that was missed. So, is it working now? It's working now. So these are what the benefits that came out of all the feedback from patients who, from participants who'd attended the programme. I won't go into them because I think Alison is going to be talking about the benefits in the evaluation, but they were describing the participants' benefits to themselves, to patients and to their organisations. And I love that quote from, I think, one of them's manager, which is, or she said, "Oh, now I can carry on for the next 20 years, Such a relief not to have to be the expert all the time and to carry that total responsibility yourself." There it is. And the other thing, of course, because it is about talking to people, isn't it? It's about talking to people, is that we can use these skills in other places. And this is our most recent survey. We were asking, is this helping you with your colleagues in your leadership role? And the majority answered yes. So if we've had such a great response, if clinicians really like it, if they feel it's making a big difference to their patients, if we absolutely know it's needed, then why is it not just happening? And I think it's because people find it really quite difficult. And it requires clinicians to be open to the fact that what we're doing isn't really working. So we need to recognise the need to change. And I think that's quite hard because we are so busy, like hamsters on a wheel, being caught up with just firefighting. It's learned behaviour, on a really busy day. It's much easier for me to sort of listen a bit, come to a solution, hand out a prescription. I mean, obviously I don't do that when I've got my health coaching hat on, but that would be, and it is relevant and appropriate with some patients, but not every patient. So it's hard to change habits and hard to be flexible because you have to sort of recover yourself between patients and then put another hat on. It can require complex interpersonal skills, which come easier to others, some rather than others. And challenging patients, we're agents for the patients. We act on their behalf. And actually, doing supportive challenge is quite difficult. With some of my patients who are obese, it's actually quite difficult even to bring up the subject of weight. So it's quite challenging. And also with health coaching, when to apply. I mean, we've got a lot of people who've been trained here, when to apply, with which patients. And that relates to their readiness to change, but also which tools and techniques we can use. It is quite complicated. But also, mainly, people say, I just don't have time to use these techniques. But I sort of slightly challenged that because we had one GP who, she said she had a patient who kept coming back all the time and would take 40 minutes and would always make her run late. And she thought, I'm not really sure about this, but I'm just going to try this. I'm just going to sit back and listen. And she sat back and listened. And she didn't interrupt. And she asked a few questions. And the patient was out in 10 minutes and said, that's the best consultation I've ever had. So I do challenge that actually it's going to take more time. The other thing I think we've found, particularly in the east of England, is that it's an educational intervention rather than a long-term management intervention. And therefore, all of the people trained have been slightly scattered rather than in specific services or teams. And it's quite difficult to do that to do something different when you're not supported by your colleagues. And I think all the research is that actually clinicians, and Angela was talking about, need to be supported by their organisation and their environment in order to use their skills most effectively. Because it is really quite contracultural. It really is quite different, although it is quite different, not when you get your head around it, but it is feel quite different to how we have been trained in a biomedical model, which is giving advice. And actually, that's what we're valued on. We're sort of valued on, I think, in medicine anyway. I'm not sure about nursing, but, if you know the most obscure disease or you can come up with a diagnosis that nobody else knows about, that's everyone goes, oh, wow, you're a really good doctor. Not because actually you really listen to patients and you might say, I'm sorry, I don't know, I'll have to go and look this up, or what do you think you could do about it? You know, it's how you're valued, I think, so it's very contracultural. But as Andrew said, I think the most important thing is that in order to activate patients, we need to be activated ourselves. We need to see that this is something that we need to do and that we need to be part of. I won't go into too much detail because I'm already overrun, but there's been a very good evidence review by the Evidence Centre. It was a rapid review over 3 weeks, so it wasn't like Angela concentrating just on RCTs, although it does include RCTs. But it does show that actually health coaching is effective, and particularly for patients in lower socioeconomic groups and people from BME backgrounds, you know, who may be more vulnerable. Which I think is really important, and it can support patients' motivation to change and adopt healthy behaviours. I mean, we do have a lot more research, and this research is basically on services, health coaching services in the States, which is very, very different from what we're doing, which is adding to the toolbox of consultation skills when we see our usual patients. So there is a lot more research we need to do. So in summary, personally, and I hope some of the clinicians here would agree with me, and there'll be some fantastic workshops after lunch, I think this is a no-brainer. I think, you know, why aren't we doing more training for skills in empathetic communication that supports patients' motivation to look after themselves, including the most disadvantaged, that improves patient and clinician satisfaction. And it looks like it might improve outcome, and it was fantastic to hear the results that Angela shared. I mean, for me, this is a no-brainer. So I really hope, really congratulate you all for being part of the pioneers, the vanguards, and I really, really hope that this can continue.
Just really quickly, just a show of hands for who has done the 2-day training in the room. Okay, so about half, I think. So we're really going to be inviting you to get involved in the workshops this afternoon and after this next session to really share your ideas and your thoughts. By no means is the product that we're offering in health coaching a completed article. It's something which we need to keep working with, developing and refining for specific circumstances. And as we often say during the trainings, the clinicians are the experts in their clinical realities, and it's for them to actually take on the concepts and ideas, grapple with them, play with them, see what's going to work best for them and their patients, and we really encourage you to do that today during the sessions. Thank you very much.